Hello and welcome to the IHI National Forum Keynote with Dr. Kedar Mate. This session is supported by the Peterson Center on Healthcare as a reflection of their commitment to improvement in healthcare. Supporters have no influence on the development or delivery of session content. Today's session will be recorded and the recording link will be available tomorrow. The PowerPoint slides will also be available tomorrow. We will be emailing all of our attendees to share how to access both, and thank you for your patience. With that, I will hand it over to Chairman of IHI's Board of Directors and President and CEO of Northwell Health, Michael Dowling.
Thank you, and welcome to the Institute for Healthcare Improvement Forum on Quality in Healthcare. I'm Mike Dowling. I'm President and CEO of Northwell Health and Chairman of IHI's Board of Directors. Typically on this day, and at this time in December, I would be standing on a stage in the largest ballroom in the US, welcoming you to this event while you sit among nearly 6,000 others committing to making healthcare better and safer. I always enjoy that moment, welcoming and kicking off the conference in a room full of people who are eager, ready to learn and talk to one another. While I can't see you in person this year, and we clearly are not together in a conference space, I can sense that you are even more committed than ever to providing safe and equitable care for the patients you serve, while being more attuned to the importance of the health of your colleagues and your own well-being. After this challenging year, I am deeply humbled by what I see healthcare professionals like you doing each and every day. The stories we hear and see about employees, including those here at Northwell and elsewhere, the work that you're doing throughout a global pandemic, the relationship formed between staff and patients and families have been extraordinary. As you will hear from our next keynote speaker, IHI has 4 values: courage, love, equity, and trust. And during the coronavirus pandemic, we have seen each of those displayed tenfold. I recently read in The Atlantic that the most precious resource the US healthcare system has in the struggle against COVID-19 isn't some miracle drug, it's the expertise of its healthcare workers. That's all of you. I want to acknowledge the deep toll that the pandemic has had on you as healthcare professionals and as mothers, fathers, sisters, brothers, grandparents, children, friends. And now I would like to ask for a brief moment of silence as we sit with our collective grief for those who have been affected and for those that have been lost. Thank you. These seem like small words that will never be enough to sum up our gratitude and appreciation. So we say again, thank you all so much. This past year, as you know very well, has been both challenging and traumatic. But I'm hopeful that this week we'll get a chance to start or continue the process of healing and recovery by acknowledging our circumstances and the grief we may feel, sharing what has worked and what hasn't, communicating with each other, and helping one another to look with hope to the future. And I do believe we have a hopeful future ahead of us. Why? Well, you are here for starters. You are here to learn about quality and safety, and you're going to bring best practices and new ideas back to your respective organizations. You're going to ensure that quality and safety is not a project, but part of your culture. The speakers we have here in many different roles, from community hospitals and health centers, academic medical centers, private practices, and everything in between, and from all across the world, give us hope as they are willing and open to sharing what they've done, what they've tried, and what has worked. It gives us hope to see the many exhibitors and sponsors who have provided financial support for this wonderful event. I'm hopeful that you see what I do, that even virtually, you're not alone, but part of a motivated and dedicated group of improvers who believe in making everything better. I am now pleased to introduce our second keynote speaker, Dr. Kedar Mate. Dr. Mate was named the new president and CEO of IHI this summer, after 9 years of working at the organization, most recently as its Chief Innovation and Education Officer. Like many of you here, Dr. Mate is both a professional and a lifelong learner. He has spent the last 20 years studying and applying the model for improvement, as well as other improvement tools and methods to make care better for all of us. He's yet another reason that I'm hopeful about our future. I believe that Dr. Mate's leadership will show the world what improvement science can and should be used to address some of the biggest challenges facing healthcare today, including the COVID-19 pandemic, as well as systemic racism. Again, I thank you for being here and for all that you do to improve health and healthcare worldwide. You are a special group of people indeed, and we should all be extremely proud of the wonderful, wonderful work that we do each and every day. Again, I want to thank our sponsor, the Peterson Center on Healthcare, for their sponsorship of this keynote. And now, please welcome Dr. Kedar Mate to our virtual stage. Thank you.
Well, thank you, Michael. I really appreciate those warm words of welcome. And it's an absolute pleasure to welcome all of you to the 32nd Annual IHI Forum. IHI has been absolutely overwhelmed by the response to this meeting, and we are humbled that you have chosen to spend your precious time with us, and honored that nearly 6,000 of you, nurses, doctors, improvers, community members, patients, and leaders, have put your trust in IHI by joining us here during these difficult times. We cannot thank you enough. And we are grateful for your patience with our technology yesterday during the pre-conference. Many of you know that we have taken the forum to many shores, but for the first time, we bring this meeting to you, to your conference rooms, to your offices, and to your homes. We experienced yesterday an unexpected technology problem and have shifted to our backup plan for today and tomorrow. We deeply appreciate your support and patience with us as we work to bring you a fabulous conference experience. Thank you as well to the 280 plus faculty members who have been navigating these technologies to bring you their very best thinking in interactive and engaging ways. And a special thanks to the IHI staff. Those of you who are veterans of the forum will know the IHI Blue Shirts, who every year get together to put on this meeting. This year's Blue Shirts will not be roaming the halls of the Marriott World Center in Orlando, but they will be in every session, working behind the scenes to ensure your experience is as enjoyable as we can possibly make it. It is now commonplace to describe the circumstances in which we are living as unusual and unprecedented. I won't add to these descriptions, which are most certainly true. I'll only pause here at the very beginning of this talk to recognize, as Michael did, and to thank every one of you for your efforts over the past year to provide the very best care and service that each of us knew how to provide to the millions of people that have moved through your service units, ER bays, operating theaters, clinics, nursing homes, and public health systems where you go to work every day. Almost everyone I know in healthcare has worked harder in this past year than they have ever worked before. And so many of us have lost someone prematurely to the unremitting ravages of this global calamity. Early in the pandemic, IHI started a website to gather some of the stories of patients and clinicians throughout our network. We wanted to help give voice to what was taking place at the front lines of clinical care so that the public could see and hopefully better understand what so many of us were seeing every day in our clinical care settings. Dr. Isabella Park from Forest Hills in Queens, New York, in the center of the pandemic early on, wrote to us just after Mother's Day. And here is her story. Mother's Day was bittersweet this year. Sunday morning, I woke up to French toast and coffee with roses from my family. My 10-year-old son and 7-year-old daughter gave me handmade cards, but couldn't give me hugs and kisses as they're accustomed to doing. After breakfast, I put on my scrubs and went to the hospital. As a palliative care doctor, I admit patients who are in the dying process and need management of their end-of-life symptoms. I had 2 female patients in their 50s on ventilators that day who were dying. After seeing them and adjusting their medications, I called their families. I updated the husband of one patient, and before we ended the call, he asked me to say Happy Mother's Day to her for their autistic adult son, who is having a terrible time with her dying. I promised I would. I promised I would say both the husband's and son's names to her. And then I called the daughter of the second patient to update her. She cried, and amidst her tears, she asked if I could tell her mother Happy Mother's Day and that she loves her so much. I promised that I would. 2 mothers, unable to go back home, unable to be visited by those who love them. I called my own mother on my car ride home and cried. And then I came home to homemade cake and cherished my Mother's Day even more because I had shared it with those families that day. Amidst stories like Dr. Park's, stories of loss and tragedy, are so many stories of courage, heroism, and our shared humanity. And many of these stories have centered on the improvers among us who are working quickly to add resilience to our care systems in ways that were inconceivable just weeks before the pandemic struck. About a month ago, I spoke to leaders in a major city who described a new citywide transportation system for COVID patients between over a dozen hospitals. This would have taken years to set up. They set it up and tested it within hours. Many have seen the conversion of conference venues like the one where this meeting might have taken place transformed into state-of-the-art field hospitals and ICUs within days. And as we speak today, there are pediatric hospital beds around the country that are being converted and used to care for young adult patients in cities where the adult bed capacity has been exhausted. Over half a dozen former IHI fellows have led national, state, and provincial responses to COVID-19 in their respective countries and geographies. And every one of those feats, and many, many more, have been accomplished by you, members of this ever-growing community of improvers who have rigorously applied quality and systems thinking to the challenge that COVID has presented us. We thank you for these efforts and also for the work that you will do in the months and years of reckoning and reconstruction that will come. It may be too early to consider what lies beyond this pandemic as we remain in the throes of this second peak, a peak that has already proven to be more widespread, promises to last longer, and that every day sets morbid new records for its lethality. It is hard to see past this moment, but we will triumph over this virus. We will win. We will beat this pandemic. I am absolutely sure of that. And we must consider now how we will respond differently today to prevent so much loss when we face the threats of tomorrow. The challenges laid bare by this virus are significant: isolation and discoordination of both individuals and systems, inequities at local and global scales, and false choices between our prosperity and our health. So how do we build a better system so that Dr. Park's patients never have to suffer alone on Mother's Day or any day? What might guide us going forward? I can't claim to have a perfect answer to this question, but I think there is an important clue about how to build a better and more resilient future in the story of this very mundane sidewalk feature, something that is commonly known as a curb cut. Bear with me while I explain here. In 1962, Edward Roberts, a polio-afflicted wheelchair-using student, became the first severely disabled person to be admitted to the University of California at Berkeley. His example gained national attention, and very soon there were other wheelchair-using students who had the courage to apply and gain admission to universities throughout the United States. At Berkeley, Ed and his colleagues moved into an empty hospital wing in Berkeley's Cowell Hospital and dubbed themselves the Rolling Quads. Mechanized wheelchairs allowed Roberts and other students relative freedom around campus, but there was an issue. In the late 60s and early 70s in Berkeley, as with most cities around the world, the typical urban landscape included sidewalks with a drop-off of at least 6 to 8 inches, without any route off of them for a wheelchair. Roberts and his colleagues grew frustrated that they couldn't use their city's sidewalks and that decisions on what classes to take depended on which streets they could navigate. And so, after a card game one night, the student activists and their supporters wheeled themselves out into the night to pour concrete off-ramps at a handful of street corners on Telegraph Avenue near the Berkeley campus, thus creating their own paths to wheeling into the city streets. Soon after that, Berkeley City Council declared it the policy of the city that all sidewalks be designed and constructed to facilitate the movement of disabled persons. Curb cuts, as they ultimately would be known, became a symbol of victory in a progressive movement toward greater rights and accommodations for individuals living with disabilities. But here's the interesting thing about these accommodations. Today, curb cuts are enjoyed not just by those using wheelchairs, but by anyone who has pushed a stroller through a busy city street, by older adults, by runners, by travelers hauling luggage, and the delivery truck drivers who are frequently bringing supplies and packages to our homes and to our businesses. My guess is many of you will enjoy a curb cut at some point today if you have a chance to take a walk outside for a few moments. Curb cuts are a universally appreciated phenomenon. The concept underpinning the wider social value of a curb cut was named some 40 years later by another Berkeleyite, Professor John A. Powell, who describes curb cuts as a foundational example of something he called targeted universalism. Powell's idea was simple but profound. We can often get to universally held societal objectives, in this case, better movement through our cities, by using targeted strategies, a curb cut, that helps to provide an advantage to those that have been systematically disadvantaged. The goal is universal, but achieving it requires multiple strategies that target the needs of various groups to help them share in that universal goal. Targeted universalism seems ready-made for today's moment and today's challenges. As with curb cuts, when you provide an advantage to the marginalized and excluded and build from there, you can end up with a system that confers a benefit to us all. Once you understand the concept of targeted universalism, you see curb cuts everywhere. Consider seatbelts, developed to protect children originally, but which have now saved the lives of over 375,000 adults and kids. Smoking laws, designed initially to protect flight attendants and later to protect restaurant and bar workers, have reduced tobacco consumption by 67% since 1965. And how many times have you enjoyed closed captioning? Designed, of course, for people with hearing loss, but used by many to help with comprehension, or if you just want to leave the screen on mute while your spouse is trying to sleep. There is a deeply held belief that when you provide an advantage to one group, it hurts the rest, that such an advantage is unfair to others. This accords with the belief that there is a small and fixed pie of available resources that we must all compete for. But as these examples illustrate, giving an advantage to one group need not disadvantage the rest. In fact, by focusing on the most marginalized and excluded, we just might create a system that is, in fact, better for all of us. Why does Curbcut Thinking matter right now? Well, the overarching reason, I believe, is that our societies are becoming increasingly polarized, and this polarization has obscured the value of cooperation when the present global moment that we are in demands exactly that. It has reduced decision-making to either-or constructs where someone has to lose, instead of seeing the opportunity that might be present in both-and solutions where multiple parties can benefit. It presents a simple us-them narrative that allows us to vilify the other instead of an us together, where we can make common cause. Much has been written and said about the divisiveness we have been experiencing and living through, but the pundits that we hear from offer few solutions. To that, I offer this simple idea. Consider the curb cut as a way of seeing through the polarization. Curb cut thinking is perhaps most easily understood in the context of creating a more equitable health system. Equity, and specifically health equity, is defined as when all people have the opportunity to achieve their full health potential, and no one is disadvantaged from achieving this potential because of their social position. 5 years ago, IHI and its partners did a study of our quality improvement work. We looked at 10 of our most successful improvement initiatives. These projects focused on patient safety, HIV, tuberculosis, maternal health, and cancer care. They were projects in the US and overseas. And all of these projects had ostensibly succeeded. Performance on the primary outcome measures had improved for patients. Lives were saved. But whose lives? Did we know the answer? Did we improve performance of the system overall, but maintain or widen disparities? For most of these projects, we hadn't collected the required demographic data that would have allowed us to even know the answer. For those where we did, disparities remained unchanged. So IHI did as it often does. We studied organizations that had made stride to close some of their equity gaps. We asked where had disparities been reduced. And what we found when we looked at systems that had closed some of their gaps was that they had done 5 essential things. They purposely focused their attention on equity and had made equity a strategic priority for their organizations. They had dedicated resources to collecting the necessary data and leveraged their quality departments to focus on inequities. They focused on specific clinical gaps and sought to understand the contributing non-medical social factors, including accessibility and affordability. They spoke openly about racism and their desire to overcome its legacy. And they formed relationships with their community partners, recognizing that the achievement of equity would require more than they had control over. To validate this theory of action to improve health equity, IHI launched a collaborative, which we called Pursuing Equity, with a group of health systems from across the US and in a handful of other countries. And the results, which continue to come in today, have been fascinating. A few examples. One health system in the Midwest observed that in their behavioral health units, patients who spoke English as a second language had a length of stay that was double the rate of English speakers. Having made that observation, this system provided simultaneous language translation services, a targeted strategy, and reduced the length of stay difference by 82% between the two populations. That was, of course, the intention of the strategy. But what else happened? Not only did ESL speakers have a shorter hospital stay, but the intervention had increased the overall capacity of the behavioral health units in the system, which had the universal effect of benefiting all patients in the community. Another example. In a health system emergency room, ER, patients presenting with symptoms of stroke had a median time to clot-busting thrombolytic therapy of 33 minutes. However, when the same ED stratified its data by race, it found that the time for a white patient to thrombolysis was 29 minutes, and the time for a Black patient was 49 minutes. As many of you know very well, when a patient is having a stroke, time equals brain. And so this observation of inequity shocked the ER leadership at the system. And within days of getting this information, they had analyzed their core processes and begun improvement activities with their clinicians. Within a month, this difference, the disparity, had been eliminated. But that isn't all. Not only had Black-white differences gotten better, but every demographic category had also gotten better. And indeed, the overall time from presentation to clot-busting treatment went down from 33 minutes to 28 minutes, 15% less time to life-altering treatment. A recent study demonstrates how Curbcut Thinking can be combined with modern tools of high reliability, including machine learning and behavioral economics. Investigators at the University of Pennsylvania randomized cancer doctors to receive training in how to have serious illness conversations about goals and expectations. In addition, on a weekly basis, a machine learning algorithm anticipated and reminded clinicians about which patients were at high risk of early mortality and therefore would benefit most from such a serious illness conversation. The goal, of course, was to increase these discussions amongst those at highest risk, and indeed that was the outcome. Among over 4,000 clinical encounters with high-risk patients, serious illness conversations happened 11.6 more often in the intervention group compared with the controls. That was the goal. Advantage the population that needed the advantage. But there was a corollary finding. Those conversations took place more often in the entire population as well, 3.3% more often overall across nearly 25,000 clinical encounters. The universal goal of having more serious illness conversation was realized again via a targeted strategy. Last year at this forum, I introduced my grandmother to many of you as I spoke about the meaning and impact that an age-friendly health system might have had on her and many older adults like her. Over the past 4 years, IHI, the John A. Hartford Foundation, the American Hospital Association, and the Catholic Health Association of the United States have combined forces to create and spread 4 key change ideas to improve care for America's seniors. Those ideas have been knowing and understanding what matters to older adults, improving medication use, increasing mobility, and improving mentation. Known now as the 4 M's, these interventions have had profound effects on older adults. Reductions in polypharmacy, delirium incidents, length of stay for our oldest adults, meaning less time to decondition and more time at home with family and friends. Back in 2017, we set a goal of reaching 1,000 systems by 2020. And with the help of many partners, as of today, I'm thrilled to report that 1,195 care settings throughout the United States have become age-friendly health systems. But while age-friendly care has had impressive results for older adults, many systems are now finding that implementing the 4 M's has benefits well beyond their elderly patients. IHI strategic partner Providence Health, having made this observation, have added a 5th M, malnutrition, and are integrating age-friendly principles across their entire system. Turns out that while age-friendly was built and targeted to benefit older adults, it has had the beneficial side effect of helping all patients receive better care. Age-friendly at every age. So how might we apply Curbcut Thinking prospectively to the challenges we face today with COVID-19? John Powell describes 5 steps for targeted universalism. First, establish a universal goal based upon a broadly shared recognition of a societal problem. Second, assess the overall performance of the system relative to the universal goal. Third, identify groups that are performing differently with respect to the goal. Fourth, understand the structures that support or impede each group or community from achieving the universally held goal. And last, develop and implement targeted strategies based on that understanding for each group that will help them get to that universal goal. There is an important rider to Powell's concept of targeted universalism. It goes something like this: if we ignore the challenges faced by the most vulnerable and the most disadvantaged among us, in time, we will find that those challenges become more grave and bigger than ever, making the pursuit of the universal goal impossible. In healthcare, ignoring the disadvantaged and the systems that perpetuate those disadvantages will lead to complications, not only in the health of individuals, but in the health of entire nations. We are living this now with COVID-19. The pandemic has alarmingly exposed every weakness of our care systems. Consider the racial inequities present in our health system and in our social systems, the systemic weaknesses of post-acute and long-term care environments, the divestment in public health and in primary care, the lack of investment in family caregiving, the intense local and regional competition between health systems that has reduced incentives over time to collaborate and coordinate. But all of these are choices that we have made, or at least that we have been complicit in making. Choices that have favored rescue medicine over preventive medicine, acute care over long-term care, commercial lives over Medicaid lives, white lives over Black lives. Many observers have warned us before about the fragility of our systems, about how those choices have made our systems unstable and vulnerable. And now we have had them all exposed and tested by a 15-gene coronavirus. But we can make different choices. As my predecessor, Don Berwick, recently wrote, "Fate will not create the new normal, choices will." So let's make different choices. What might we do differently? How can we recover faster and better than before? I think we find the curb cuts. Knowing the differential impact of COVID on Black and Latinx populations here in the US, we should seek targeted universalism. We should intentionally design vaccine distribution and delivery systems that anticipate the legacy of medical racism and distrust. If we reshape our care delivery systems in a way that builds trust from the start and recognizes racism and other forms of historical oppression, we just might create a different health system. One that has the result of freeing every one of us from this scourge faster and more completely than if we do not. We should reinvest in and elevate our public health system, transforming it into one that reaches far into remote and rural environments, one that builds relationships with all populations through a robust system of well-paid community health workers and peer navigators, one that creates collaborative connections between healthcare institutions and their communities. A public health service corps will create jobs. It will begin the important project of sewing up the gaping holes in the safety net, and it will stand ready to protect all of us when the next threat, which will come, emerges in our communities. We have to fix our long-term care environments. Our nursing homes need our support right now, not our suspicion, distrust, or derision. The people that work in our nation's nursing homes are some of the most committed I have ever had the pleasure of meeting. In the past few months, IHI has partnered with our colleagues at Project ECHO and AHRQ to launch a massive national network that has already now reached over 7,500 nursing homes with a combination of the latest and best clinical information on COVID-19 and systems improvement methods that ensure reliable implementation of that clinical wisdom. As we have done this work, I've heard stories of countless nursing assistants who are not paid nearly enough, who have left their families at home and moved into the nursing home to reduce the risk of exposure to their residents. Our nursing homes need staff, they need supplies, they need better spaces and better systems of management and support. We must focus on our nursing homes because we will not get to universally better care and we will not beat this pandemic without them. And speaking of vulnerability, we really need to understand and re-examine our national habit of detention and incarceration. Our nation's jails and prisons have been hotbeds of the virus, adding an inhumane penalty on top of the daily challenges suffered by the over 10 million people that pass through these settings annually in the United States. We should build targeted strategies that focus on decarceration to release as many as we can from our overcrowded jails. We should expand community-based behavioral health services and deliver much better clinical care to those who cannot leave our prisons and jails. Without these strategies, the revolving door between communities and our detention centers will hinder our ability to end this pandemic. So how do we each get a start on these ideas tomorrow? What might each of us do to create our own curb cuts? 3 ideas to get started. First, name the universal goals that we are trying to achieve. Name them, and then recognize how not all groups start from an even playing field to get to those goals. Second, consider your own equity practice. Pick a measure that is important to you. Maybe it's your C-section rate if you're an obstetrician, complication rates for surgeons, cancer survival if you're an oncologist. Pick a measure and stratify your data by race, ethnicity, and language. You will learn something for sure, I promise you, and it may invite opportunities to make improvements. Lastly, we cannot create the curb cuts of the future unless we take care of ourselves and each other. We need not only the PPE we wear to physically shield us from this virus, but we need the psychological PPE that can safeguard our minds and souls as we work to save as many lives as we can. It is rare to have a singular health goal for the planet, and yet today we have just that. End the pandemic, end the suffering, end the death. That is the universal human goal of this moment. To achieve that universal, we will need targeted strategies. Strategies that advantage both the people that have been left behind and the systems that we have historically undermined and ignored. And in so doing, by creating new advantages, we will honor those that we have lost too early, because we will have permanently remade our systems to reduce the risk of future pandemics. We will have built a better normal, not just a new one, because we will have found that by advantaging others, we all achieve the universal. I thank you for being with us here at the IHI Forum. We are honored to have you here.
Thank you, Kedar, so much for that wonderful keynote. And thank you to you, our participants, for joining us today. Next up are the A sessions from 11 a.m. to 12 p.m. Eastern. You can join the A session of your choice by going back to the virtual lobby, www.ihi.org/forum lobby. Thank you again to our sponsor, the Peterson Center on Healthcare. Enjoy the rest of the forum.